which that'll take us probably about 50 slides, whatever that is. Because then we go into talking about like the rotator cuff and things, and I don't want to get a couple of slides into it. I don't like to do that. It's a good breaking point, so we'll, if you're one of those who counts till I'm gone for the morning or something, there you go. Surface anatomy of the pectoral back and pectoral region. I use a lot of these just to reference when you're looking at the patient. Because it's one of those things, what seems obvious, like if I'm doing a patient or somebody who's already finished PA school or somebody who has medical experience, you're looking at, well, yeah, of course that's the medial or vertebral border of the scapula. Other people aren't used to this. So I put up these pictures that are kind of basic, saying, here's your vertebral borders of your scapula. You have the vertebral furrow. There. Alright, so you can't pay, I say this every time, I'm running my own joke. You can't just copyright pictures, so I have to do my own modeling. It gets a laugh every time. That time I gotta start coming clean, that's not me. Yeah, I could have been. I did start running again, I didn't tell y'all that. Yeah. Because I got pissed off at my family. And my daughters were talking, I said something about running.
Didn't even change.
And they said something and I went, what do you mean I don't run? I ran for so long and I used to love running. They're like, you don't run. And I was thinking back, y'all must have been too young. And they're like, well, I remember you telling us you can't outrun me. And I said, you have never officially outrun me. And they're like, they don't even want to, let's just go out there now. Because I told you, I can do anything I want. So they died. They're going to beat me. I'm not saying that. They're going to beat me. But I used to tell them when I was young, it's just like if you play me in basketball, I'm that daddy. You're not winning unless you win. Sorry. I'll give you a little break here, and I'm not going to demoralize you, but if I have to block that last shot we were about to win, I'm going to block it. But anyway, so they're all talking about this at the table, saying, well, you don't run. I said, you been on a long time. Then my wife chimes in, I said, when did you run so much? I'm like, you were married to me the whole time. I said, that's it. And then I didn't think anything else of it. We thought it had friends' house. And anyway, we were eating dinner there. And I said, hey, we should all go. Way back in the 90s, I ran the Halloween Marathon as like a joke. I said, well, we should all go and plan a trip to Hawaii. And all the kids and us, and we'll run like 26 December. You got to plan that way out. I said, now that everybody's going to be out of high school and college, let's go run a Halloween Marathon like as a family. This lady that reading looks at me and goes, you're going to run the marathon? I'm like, oh my goodness, that's it. That's it. So I'm back on. I'm not saying I'm doing well yet. I'm going to get there. Just saying that out loud. It's like saying, hey, I quit smoking.
Yeah, now you're accountable.
Yeah, now I'm accountable.
Yeah, quit cigarettes. Straight
to cigarettes. Anyway, nobody cares about all that. Yeah, I don't care about a lot of things I'm talking about. I love that y'all smile and act like you do something. Okay, trapezius, very large muscle at the back. Often referred to, a lot of people say your traps, right? That's your trapezius on each side. If you don't realize that there's one over here. If you look at where the scapula, where we think it lies, you also have latissimus dorsi. So latissimus dorsi is very large, so we'll look at the actual picture, the actual region where the bulk of it is. And remember, it helps to form the posterior axillary fold, along with teres major. We get over here and we see this is teres major arm. Abducted now so you can see teres major. So both of those help to form the lateral border. Another large muscle on the upper extremity is the deltoid. This was when I took over the course, this was my favorite picture because I could not figure out why it wasn't cropped. Because, and actually there was a lot of them in the slide set that weren't cropped. And I don't see the need to show the fact that the guy is wearing a Speedo. We're not talking lower extremity or reproduction. We're talking about and so I had to go and crop that out. So that's your deltoid. I don't know. I guess the last person who ever had these years and years ago had some of these pictures up that where they were in the bodybuilding. I don't know. You have no benefit of the doubt. They are AC, right? AC drug. We talk about acromioclavicular. We said yes, that's the highest point on your pectoral girdle. We say shoulder, right? And that's the point that you can read jugular notch. You can see. Right? So you start looking for KVD beside it and all that. You can't throw up these pictures without having Arnold in the glory days, right? Pectoralis major. That is the most superficial muscle of the anterior thoracic wall. Because when we look at the origin, we're going to see that that has a huge origin all the way along the clavicle, down the sternum, the ribs. And that muscle is actually what forms the anterior axillary fold. Another one that we see in a lot of individuals, serratus anterior, it's on the anterolateral side of the thorax. It runs right along the ribs. Right? Not prevalent. Well, not prevalent's not the word. A lot of people you don't see that as developed. But obviously in Arnold here you can. But that's not what I like about this picture though. This is my favorite part of this picture. What's this? As long as he's sucking in his gut. He doesn't have a gut, but he's sucking in. What do you think I just underlined? Liver. Like, holy crap. That's the buddy you want during physical exam testing. You got to palpate the liver. You're like, yeah, I have to look for it. Surface anatomy continued. I got a lot of these in the beginning. Obviously, most of us know our axilla. If people put the deodorant on, even though I've been reading stuff that say that there's a big kick if people are going non-deodorant, going to Europe style, I guess. Not going to happen. You do what you want to do, though. I mean, this is the weekend at the beach. Going to work, though. Let's throw some deodorant on. It is probably killing you, though. It is just another chemical, right? Put it on your body. Biceps brachii and triceps easily seen. Nowadays, this I probably believe that really is me nowadays, so just continue the joke there. You got your biceps and your triceps. On the elbow, you have the organon process, and just above that there you have the lateral epicondyle. We mention the lateral medial epicondyles a lot because most of the forearm muscles originate off of it. I say most, not all. And then we look at some of the veins, and we'll get into the actions after this. So, when we do normal vena puncture, what we mean by saying that is most people, if you say, hey, go give this person an IV, they're going to go right for the cubital fossa, right? We're going to go right there. Unless you've had more training in IVs or you've done emergency medicine, special operations, please tell me why you're doing it. But the most common vein used is the median cubital vein, which runs across. There's some variance in the way veins are set up in the cubital fossa, but the median cubital vein is the number one, they say, used vein for normal vena puncture. You know, if you're in a hospital, even during a code, you're not going to go start the median cubital vein. You're going to start low and start working your way up. The reason for that is let's say that you start here at the cubital fossa and you miss. You go through the vein. Well, guess what? Unless you got somebody standing in the room that can do a PICC line right away, you as a provider, even as a PA, I mean, I shouldn't have used emergency medicine, that's a little different, but during a code, you get to that area, you come in and somebody's already hit the elbow, you got to switch. You go to an arm, you go to a foot, whatever, because most people aren't really on their scope of practice to do IVs above the elbow. Do we do it in the military and like special operations? You betcha. all, I'm not sorry. They use all sorts of fancy ways to get fluids in you that I'm not going to go into. But the average person, like a medic, better not be sticking somebody above the elbow in a, I don't know how to explain that. Practice rules, you know, right? Anything about that, like you do a pick line. A pick line goes from there all the way apart. You gotta get it finished to make sure it's in place, right? But the point I didn't even get into all that. The point I was trying to make is that you want to start low, go high, because if you go here, you can't go below that. You can't go below. You gotta start low and work your way up. If you go into like an emergency room, not emergency, like OR prep, you'll see there's normally probably backs and hands, which was the biggest challenge for me when you go in there, back when I was a medic in Hawaii, you go in there and an 80-year-old lady, do they want you to put a 16 in the back of their hand? You know what I mean? Like, hold still. You're not moving, but that vein is. It looks like this small, it looks like you need reading glasses. But you want to get good IVs, so do OR prep for a little bit. Okay. Elevation, compression. Elevation, I don't know. One of my favorite terms nowadays, and I don't know. I mean, I get that stuff all the time, and I just say, I don't know. You know, and I realize I'm getting older and crankier, and I just say I don't know, because I don't want to talk about it. I don't know. Hey, do you know how to change a tire? I don't want to talk about it. You change your own tire. That's a joke. Depression, right? Depression, the shoulders are drooped, right? They drop down. Other actions that you're not associated with other joints in the shoulder, we have what's called retraction and protraction. So retraction would be bringing essentially the scapulus closer to the vertebral border. So bringing it in this way. And he's doing, you know, like he's puffing out his chest, but same action would occur if you were like rowing a boat. I mean, bringing your arms back. You're bringing those medial borders together. And then protractions, like if you've ever been to the doctor and they say, and you're going to do this with your patients, you want to listen to the heart better, listening on the backside, you know, across the arms, kind of bend over. We'll talk about there's a triangle. You can move some of the musculature out of the way. So you get here, triangle of auscultation. We'll talk about that. That brings your scapulas out also. So that's protraction, retraction. Which technically, if you said that the scapula, you could also say the scapula is being adducted or abducted too, right? Anytime it moves to the midline away, they just call it something different here. We see that throughout the extremities. Like when you get to the hand, we have abduction and adduction. I don't call it that. They call it medial and radial deviation. I'll explain that when we get to it. And the last action is upward rotation. So upward rotation means bringing your arms overhead. We often think about the shoulder, but there's more than one joint in the shoulder. That's the glenohumeral joint. Yes, it has to move, but what also has to happen, and you can't do it on a skeleton, is when you take your arms and bring them up overhead, remember you have the scapula here, they're going to upwardly rotate. You can kind of feel that in yourself. You bring your arms up, you can feel the scapula, and they're kind of rotating. And there's downward rotation. I just didn't put a slide on. Right, so I promised you before that we're going to do a regional approach, and that I would explain to you each vessel that I want you to know. So I guarantee on these pictures, what box is all we're going to go. And it simplifies things great, because if you go back and look at the whole body picture of the upper extremity, there's a lot of vessels labeled on there, right? And there's labels everywhere. We're going to worry about the main veins. Okay. So as we talk about the upper extremity, we got to look at the pectoral girdle region, the arm, and then the forearm. And we'll do that in each one of their sections. But for now, this is kind of an overview of how we'll look at it. You have the axillary arm. And then later we'll see, I'll give you a landmark where it's going to change from the brachial artery all the way down to the elbow. And then it's going to split and go into the forearm. there's one other vessel that we'll talk about later that comes off of the brachial. But other than that, that's all the vessels we're going to look at in the upper extremity. So that's going to simplify those for us. Well, not the only arteries. But we got to look at the venous side. So venous going back towards the heart, like all systems, we have superficial and deep. So axillary artery, we're going to do an axillary vein. When you look at superficial, meaning the ones that we can see, or the ones that we might do like a pick line in, right above the elbow, you can go up here. Immediately on the arm, you have the stomach. And then laterally, you have the spine. They're going to meet up at the cubital fossa where we can see those vessels, and we're going to do our IV. Remember the variation. This area, if you get through the blood online, you'll see the variation to how these are linked. But we're just taking a picture here and saying, well, crossing the cubital fossa there, your elbow is the right median cubital. Most commonly IV access. And then the cephalic continues down the lateral side of the forearm, and then you have the basilic that continues down the medial side of the forearm. The only other vessel, superficial vessel for veins you need to know is there is the it comes right here, kind of in the middle of the forearm, called the right median antebrachial. I didn't know the. I keep saying arm, but the arm is the brachial region. That's why it has the brachial artery. That's why it has triceps brachii. Below the elbow to the wrist, that is the antebrachial region. So you can refer to them both ways. And that helps you when you're looking at these vessels to say, well, that's antebrachial. Okay, we know that's in the forearm. In the deep. Right? Here's a generality. If we have an artery that's deep, we're going to have a vein that's deep with it, and they're going to be named the same. So we don't always have to just keep pointing that out, but you have the right axillary vein. We already mentioned that on the superficial slide. And then we have the right brachial vein, kind of convoluted in there. And then you have I keep saying ulnar and radial deep veins, because we have radial arteries. See the axillary vein on both of these, because the superficial veins and the deep veins of the forearm, the upper extremity, both going into the axillary vein, right, on its way back to the heart. When we look at muscles, we got to separate them. This is where we start to decompartment. I told somebody again yesterday, I keep telling y'all, hopefully tomorrow we'll be into our actual arm compartments. We're still have different muscles in the back. When it comes to the upper extremity, I think two of the more challenging muscle groups are looking at the shoulder itself, specifically these superficial kind of back muscles, because their innervations aren't as easy to pick up on as saying like the median or epicondyles, all the flexors of the forearm come off of that. Most of those are innervated by the median nerve. You get up to this scapular area, you're going to have different nerve centers. There's not as much overlap with the innervation. But we'll get there. So we have the superficial layers, and when we say superficial layers, muscle of the back, we're separating them from the deeper layers. The deeper layers like those rotate by spine muscles. When you look at muscles that move the neck, the vertebral column, all those are deep layers. The superficial have upper limb muscles, that is the most superficial group, and then you have some intermediate muscles that are often associated with respiration. Specifically, they're accessory muscles of respiration. You don't need them unless you're not doing normal quiet breathing. Doing labored breathing, you would use them. Going too fast, we don't want to get through rotator cuff. We just last test block just did had a note that said we're not going to study these here. We're going to study only the upper extremity, and now we're here to study those. So anteriorly, the muscles that we see are pectoralis minor. You have serratus anterior. Even though serratus anterior is really anterior lateral on the sides, they consider that an anterior group there. And then you have subclavius, the real small muscle up by your first rib. Posteriorly, we have a very large trapezius and latissimus dorsi, and then you have your scapula and your rhomboids, which we have a major and minor. As we list, we're going to list all the muscles in this group and then go over them individually. And so I think I roll through those. If you look at pectoralis major, and I don't know why it's missing its origin and insertion. I guess this one back on there. That's all right though, because I know what it is. I don't have anything funny. Pectoralis major originates, now I can draw fighting O's, little O's, and its origin is off of the clavicle and down the sternum and kind of attaching to the ribs there. So this origin, that's supposed to be an O. Origin is very broad. Its insertion is right here on the humerus. So it is inserting into the intertubercular sulcus, or what's called the bicipital groove. There are several muscles that we're going to see that insert at that bicipital groove. Now, if we learn the origin and insertion, we look at its action. Pulling the insertion towards the origin, which is the way most muscles function. Some can do opposite ways. Most of the time you're looking at it, I'm going to pull the insertion towards the origin. If I do that, that's going to bring my arm towards midline. So that's adducting. But this is where you have to understand, like the pectoralis major is here, and it's inserting, I'll just use one finger, inserting here. If I pull, think about y-axis. When you talk about medial and lateral rotation, or internal and external deviation, those are the, you can use them both. If you're talking about turning it this way, if I have a pectoralis major muscle that comes out and it's attaching here, inserting right here, it's going to pull this way. So if it pulls, turn it in. Does that make sense? You're going to need that because there's a lot of them that do rotations, but when you look at like latissimus dorsi, it's on the back, but it also does internal rotation or medial rotation. I'll show you how that happens when we get there. So it's pulling this way, so it can pull it towards midline and also immediately rotate it. And it's innervated, it's very large muscle, so when you compare pectoralis minor, you need every benefit, anything I can say to help you remember the differences in some of these nerves. So I say a lot of ways I remember. Pectoralis major is obviously larger than pectoralis minor. There are two pectoral nerves, and so pectoralis major, because it's so large, is innervated by both of them. Medial and lateral pectoral nerves, the name for the muscle. Pectoralis minor is innervated by just the medial pectoral nerve. Not the easiest way to remember something, but if you're coming down and you're splitting hairs, whether it's benign, it sure helps you, right? Pectoralis minor is much smaller. It originates off of, doesn't ribs 3 to 5 generally. And it hurts. Remember, this is the acromion of the scapula, and this is the coracoid process, the beak. So it's going to insert the coracoid process, and so we look at that and say, well, that means that we're going to pull this way. So if it pulls that way, and we look at abduction, I said you can call protraction abduction, right? Moving the scapulas out. So it's attached to the coracoid. That's part of the scapula. You need to be able to see it better on the skeleton again. So if I have pectoralis minor here, and it's attached to the coracoid process, when it pulls this way, that's going to pull going to pull it by pulling on the chrome unit and the abductor scapula. Protract it. Bring it out. There. But, do you remember fixators and stabilizers? Kind of discussed that. If you tighten muscles, then you're having like asthma, you're trying to breathe. This muscle can actually help. For formulation, it can actually. Y'all just finished respiratory, right? You tested on it yet? See, they're not. Remember, when you want to enlarge the thoracic cavity, you want to bring those ribs up and out, correct? Pectoralis minor is here. Its origin is these couple of ribs and it inserts here. If you tighten, you don't know which ones. If you tighten muscles down, let's say, have you ever seen anybody in an asthma attack? Right? And you're seeing all those muscles tighten up. Well, when the shoulder muscles tighten up and you contract pectoralis minor, it can help bring the ribcage up. Do you need more clarification on that? See, I worked it in for yesterday. Does that make sense? It's pulling this way because these muscles are letting it do that. But if I tighten on my shoulder muscles down and you tighten that muscle, it can help pull it up. All right. I already said it's needle. Serratus anterior. So its origin is along the ribs, almost all of them, that's fine. And it inserts. Now, all of this is the origin of serratus anterior. The insertion point is the vertebral border and inferior angle of the scapula. So that I'm going to come back and show you how that runs. When we talk about the action of this is it abducts the scapula and rotates it upward. This is another muscle. If you fix the muscles in the back, this muscle can help you kind of, not real well, but it can help somewhat to elevate the muscle. It's called the boxer's muscle because when you do horizontal motions, like drawing a punch along with teres major, you're using a lot of that. So let's look at how it's situated there. All right. These papers. So when you look at serratus anterior, it says that it abducts the scapula, but it's inserting. It's out here, but its origins are all on this wire is, but it inserts here on the medial border inferior angle of the scapula. So what it's doing is it's coming off of the ribs here, and it's going under the scapula. Yeah, see that? So it runs under and it attaches here. So when you pull it, if I'm pulling this way, I'm going to pull the scapula into abduction, or what we call protraction. I'm going to pull this way. Oh, I forget about that. Of course, now that I say that, I'm like, oh, I forget. He's way over there. He's asleep. That's not what I'm going to do that today. I felt guilty about giving him a hard time to practice. Yeah, I didn't mean to make y'all laugh about it, but I felt guilty about that all day. So you're going to pull this into abduction or protraction, and that's also upward elevation. There you can do upward elevation. So this is one of the muscles that we see that kind of doesn't make sense at first until you kind of lay it out. The reason we're pointing that out is that serratus anterior is one of the muscles that's very responsible for keeping that scapula tight against the thoracic cage in the posterior side. And if we were back kind of mentioned, you have articular connections of the pectoral girdle out front with large muscles over it. In the back, there are no bony articulations. The only thing holding your scapula to the thorax is muscle. Serratus anterior is one of the big ones for that. Because we're going to talk about what happens when you injure the nerve that goes with it. So, I'm not going to go into this picture, so don't even start trying to figure it out. Just show you a view of it. I used to, but it became nonsense for y'all. Right? The nerve that enters tools, but out south, right? It goes all the way along thoracic nerve. So if you have a lung, this will help your career. I put it in there. Is a lung thoracic nerve injury leads to paralysis of serratus anterior. What's going to happen is when this person tries to raise their arm over their head, right, you look at the vertebral border and anterior angle of the scapula pull away from the thoracic wall. And because of that, you won't be able to abduct your arm past nicely. You won't be able to get past here. That's the medicine. You could, can you? Maybe. Think if this is serratus anterior and it's attached over here, and it starts to pull this way, we're pulling it, and it's not held down, this muscle is paralyzed, there are other muscles that move the scapula, right? So the other muscles are still going to move the scapula, but I told you serratus anterior's biggest job is holding the scapula down from the posterior side. And so if it's weak and the other muscles move it, the scapula is going to wing this way and up. That's called a winged scapula. That's what it looks like. So this person's trying to bring their arms overhead, and over here you can see they have a winged scapula. I had a student in a few classes ago that he had both scapulas winged when he did that. But he could get his arms over his head just fine. He was born that way. That's why a second ago I went, well, not always. Not everybody's normal. Actually, nobody's normal. Normal is you. I had a student, I told everybody you're just I had a student, and I got a picture, she doesn't have C1. I don't know. That's why I always say, not everybody's normal, but we study normal. Another way you can have people do this is put them on the wall and push, so they're winning that scapula out. But that's, I guarantee you that will come up during the physical exams. So we'll see that. And we look at subclavius, the very strong muscle. Have you ever heard things like first rib syndrome? It's your biceps muscle. Subclavius reaches off of the first rib and it starts off the clavicle. And its job is to help depress the clavicle and moves it anteriorly. Not going to see a lot of use, a lot of motion out of this muscle. Basically, the thing to kind of remember about the subclavius is it helps to stabilize the pectoral girdle. Because it's going from a rib to a clavicle. So, and luckily for us, the innervation for subclavius is the nerve to the subclavius. I love it when something like that. On the subclavian nerve, you can say it anyway. There's a lot going through. So just every time you read a slide, if you've never studied muscles before, just tell yourself in your mind, thank goodness I don't have to know the origin of assertion. Because that's what the people who've studied before are thinking. They're like, you just want me to know the action again? But anyone who's ever knows, you know the origin of assertion, it does help. It just sucks to have to test on it. Not bad. No, you're perfect. PA is not even close to perfect on this. It's a thing we have to do. Trapezius. Very, very large muscle. I was trying to give you a break. I've been drumming around. Trapezius is extended. I didn't put it on your skulls up here. You have your external occipital protuberance, or that drill sergeant's bone. That's part of its origin. The superior nuchal line right here, it attaches to that also. The nuchal ligament, and on the side process, that's C7 to T12. Why do we skip C1 to C6? Because it attaches to the nuchal ligament, which goes front of those, right? So then it extends origin. It is going to insert around the top of the shoulder. So it's going to insert along the spine of the scapula, the acromion. You can't see it here, but around the clavicle. So if we look at the spine of the scapula to the acromion and along the clavicle. So the insertion point for trapezius is also the origin for, I guess, the deltoid. The deltoid, we're going to switch it. The origin of the deltoid is the spine of the scapula, the acromion, and the clavicle, and it inserts at the deltoid too. So the insertion and origin of these two muscles are in the same place. The reason I'm comparing it to that is because some muscles are multi-pennant. Remember, the deltoid is a multi-pennant muscle. When you look at trapezius, it does similar. These are muscles that do more than one action. So if you look at the superior fibers of trapezius, up here, scapula and extend. That's the superior fiber. And then the middle fibers that we find in here are going to help to add the scapula. And then the inferior fibers that are down here are going to help to depress the scapula. Bring it down into our sac. We already know from cranial nerves that sternocleidomastoid, and when we look at we know that's cranial nerve 11. So that's what innervates is. Another large muscle, latissimus dorsi. Its origin starts the lower 6 thoracic vertebrae. It's going to go through basically T1 to L5. And then it expands out. That's all origin. And then it expands out along the iliac crest. So it's going to be a very broad muscle that goes there and makes its insertion point at the intertubercular groove, occipital groove. So that we have a dotted line here because it's not inserting at the back of the tumor, it's inserting at the anterior side. So if I go back to the paper and say, well, latissimus dorsi, what it's going to do is it's going to originate all through this skin, and then it's going to come up and make its insertion point out here. It's coming through the axillary region and coming up and inserting anteriorly. So now we know that pectoralis major and latissimus dorsi both insert the anterior sulcus. Pectoralis major pulled it this way, and that caused medial rotation, right? Latissimus dorsi, when you look at its actions, and that's why I feel negative to say it extends at us and immediately rotates the humerus. If you don't realize that it's going through the axillaris and inserting anteriorly, it's still inserting where I drew. Now, if it was inserting posteriorly right there, then when it pulled, it would actually do external rotation. It would not need to rotate it. But since it goes through there, it doesn't medial rotation. If you think about opposite actions when you're actually climbing, doing pull-ups, we'll use this dorsi. It's going to help with that action also. Raising the body, right? So instead of pulling down, now pulling the whole body up. This dorsi will help you with that. And I told you these superficial back when it comes to innervations, some sound a lot the same. Dorsal nerve. I have no way for you to remember that other than coming up with it's on the dorsal thorax. Right? The muscular tract. Problem is when people throw in and go axillary nerve in your options, and you're like, oh, it does go through the axilla. Right? Oh, it's going through the axilla, and you start second guessing. Thoracodorsal. Levator scapulae. When you look at levator scapulae, it's superior 4 to 5 vertebrae is its it inserts at the superior vertebral border of the scapula. You know, closer to that superior angle. The pictures aren't always exact, right? So that's the superior border of the scapula. So its job is going to be to elevate the scapula. And no easy way is the dorsal scapular nerve, which now sounds very much like thoracodorsal nerve. I know. I had to go through them myself. It's the dorsal scapular nerve. I guess the big difference there is it has scapular and this one doesn't. Right, trapezius, leaving the scapula in place, along with a lot of the foreline musculature. I tripped this down. This is latissimus dorsi. Here we have trapezius. You have your deltoid out here. And we've removed trapezius on the right side. We'll get to these here in just a second. We have rhomboids that are here. So let's turn it on their all side. Right, 3 more slides. We're going to take a break. I'm kind of killing y'all, but just kind of know the way to go through these and just getting through them. When you look at rhomboid major, rhomboid major originates off the spine's process as the T2 to T5. So that means they're originating out here. There is a rhomboid minor. We refer to them as the rhomboids generally, but we're going to separate them here. So the insertion for rhomboid major is the medial border of the scapula below the scapular spine. That's its insertion. So it's going to pull this way, which in some ways helps to elevate, but definitely helps to retract the scapula, adduct that scapula, bring it closer to the vertebral furrow, bring it closer to midline, and posterior exterior. And it also helps to fix the scapula down to the thoracic wall. Most of the action that we discussed with the rhomboids adduction, but really retraction, right? That's you're rowing a lot of those rhomboids to do. When your arm back to throw a fist, right? A lot of your rhomboids going to that is only major. When you look at rhomboid minor, its origin is higher, C7, T1, and it starts on the border of the scapula, but above the scapular spine. So that's the side point. I know the picture doesn't look like that, but certainly in the lab they will next week. When you look for the scapular spine, and you say, well, you have rhomboid minor, and it inserts above the scapular spine, and rhomboid major inserts below the scapular spine. They do the exact same action. So elevate and adduct the scapula, elevate and retract, right? And it fixes the scapula to the thoracic wall. When you look at both of these, dorsal scapular nerve. Now you can see why once you get out and down, making stuff you're talking about the rhomboid point, you never break it down into rhomboid major or minor. You just say rhomboid. Last part here, if we look at all those muscles that are, especially anybody who has extra adipose tissue or large musculature, right? They're really work out. I'm sure we're looking at like Arnold Schwarzenegger's back muscles in that picture. They're probably pretty bulky. It may be to listen to your lung fills when you're trying to posteriorly do auscultation. So there's an area called the triangle auscultation. You definitely need to learn the borders of this for me and for physical exam. Because it's not, I don't skip the borders here because you need to know for physical exams, you might as well learn them here. At least see them once. So the triangle is formed on the posterior side. It makes it easier to hear the lung fills back there. So there is a border, it's the superior border of the latissimus dorsi. Here. This is your latissimus dorsi. This is trapezius. in this area helps you to hear better with the stethoscope is going to do the action that causes protraction, but it's really moving all those out of the way. So when you're like this and kind of bend over like the doctor asked you to do, all of that muscular kind of moves out of the way and you can put a stethoscope here and hear the lung sounds better. One of those things you got to know. Most people, I was taught by my counselor. I mean, I really don't, I said I only saw my counselor like twice while I was here the whole time. Most of those were crazy. You know? One used to tell him I shut up, and the next kicked me out of the office. I told you that story. I saw him at graduation. But I lie a little bit because he would always be at physical exam. So we had to go practice physical exam on each other. Anything, look at stethoscopes, wherever it might be, he would always be there. And when he was in the room, you were on pins and needles. Because he was loud. You'd hear him from across the way. And if you picture the first unit, when you first showed up, your private didn't know any better. You're right into that son of major that's old, rough, spitting in your face, yelling at you. Y'all know these people, right? And when you're private, that person stares you more than that butterfly lieutenant does. He stares you down. That was him. And you hear him across the room. Oh, what are you doing? It'd be something simple like you have the otoscope, and you're looking in the air, and you have to keep yourself from poking to the air drum. But he was, I want to say, very, very dedicated to making sure you knew how to do it right. Even when he yells at you, so I'm not trying to put it together. I don't know how Brian yells. I wish he taught me this. I may have told you this already. Did I tell you he told me to always put a stethoscope on a patient, no matter what they're there for? Yeah. Makes them think you care. Makes you did something good today. Don't be afraid to put your hands on patients. I don't mean it the way it sounded. All right, let's take a break. I'll tell you about the first day. You know that? He's saying I didn't tell you the story about the first day of my counselor. All right, that story's coming out.
cigarettes.